Yeah.
We don't sign in. Try this year's template.
Good morning.
How are you?
Good. How are you doing?
Okay, self-construction again. I know it's in the right place.
You gotta pick the place very carefully. To know which roaster you're
Never know.
creating, right?
Yeah, my mom's love it.
How long do you think the construction will be going before you retire?
Karen.
Well, I might have to like say no. I just call one now. Build it. Pretty building cases.
Yeah.
Actually, you see that. Yeah, it's actually much easier.
Oh, okay. Just locked in my Supreme Court, something around, right? July, I got 1.1.
You said you got caught up there. Goodness. How's your son?
Almost like 4.7.
Did you? Don't pay attention. People don't pay attention.
Yeah, I wasn't.
It is.
The handles for the board. It doesn't all. And it's a chick magnet. How's your summer?
Trying to get an industry IT.
Been there, been through all of that. I understand completely. Yeah.
I bring them back home. I'm just putting this like too much.
Everything going well? Yeah.
Oh, yeah, we're okay.
Right.
I just have to change my schedule.
Oh, yeah.
Well, I did
about 30 to 40 people that way too.
Wouldn't want to go out.
Not much. She told me, like, give me a baby.
Free care out of these pretty much just
Today's the last day.
Can I get everybody to sit down? Dave Golden's got a fairly tight connection with a flight this morning, and we want to get a full presentation and a case presentation in. And I promised that we'd have him out the door at 8:30. So.
All right, so the word of the day is Venom allergy. It's right here, and hopefully at the beginning of every talk.
How many faculties there are?
Just a quick reminder about how to get to it. Go to your online invitation. At the bottom, it's a Catalyst link. Go here. It's very easy. Very quick. Put your name in here. Put the talk, so Dr. Golden's talk here, and then put the word of the day below. You can either continue with the evaluation, which we strongly encourage, or you can skip the evaluation, and that's all you need to do. So it's usually pretty quick. So I'll let Dr. Golden get to his talk here. And let me know if there are any questions that come up. You can email me.
So again, the agenda for today, Dave Golden's going to give us his presentation, starting in just about 30 seconds on an update on stinging insect allergy, and then we've got a case, and as opposed, we don't really have time to take a coffee break. We're going to move just quickly from one to the other because he's got a flight to catch, but we want his insight, and so Aaron's going to very briefly present him a case. So it's an honor really to have Dave Golden here from Hopkins, clearly maybe the leading expert on venom allergy in the United States. Dave, thanks for coming. It's all yours.
Thanks very much. Thanks for inviting me. It's great to be here. Great to see some familiar faces. I'm going to try to combine an overview of clinical approaches to insect sting allergy and try to put in as well some of the recent papers that have caught our attention, both clinically and, I might say lab and basic observations that have a real bearing on our clinical approach. So, of course, the obligatory disclosures, I do have involvements with a number of companies that have their hands one way or another in anaphylaxis and insect allergy, both on the diagnostic side, but I'd like to say that I don't feel that I generate any actual conflicts of interest, but there are clearly potentials here, so there they are. And of course, we're talking about stinging insects as opposed to biting insects. So honeybees, which are pretty docile, you have to get one pretty angry to sting you. And then yellow jackets on the upper left and a kind of a wasp on the lower right, which most people, including me, probably couldn't tell the difference without close inspection, which we don't normally do with stinging insects. Pause and take a close look. And the bald-faced or white-faced hornets that make these huge nests up in the trees and bushes, they're definitely very aggressive. They hate vibration. If you're out there with a lawnmower or weed whacker or anything else that's vibrating near their nest, they may very well swarm and attack you. So epidemiologically, if you ask a random sample of adults whether they've had a systemic reaction to a sting, we got a history that was convincing to us of systemic reaction to a sting in 3% of the adults that we surveyed. This was quite a few years ago. I'm not sure I believe that it's changed either way, up or down, but there are studies in other countries that are actually in the same ballpark. The estimate of 1% in children actually dates back to the cetipanes in Rhode Island in the 60s, publishing this 0.4 to 0.8%. We know that was an underestimate because of the way the study was done, so we're going to estimate about 1% of children have a history of systemic reaction to a sting. There are no better data, unfortunately, in children. But if you go and skin test or do serum IgE tests, and I'm going to try very hard not to use the word RAST because it's no longer an accurate acronym for the test that we use. So the folks that create our practice parameters and guidelines for diagnostic testing made a very strong point that this is a term that we shouldn't be using. Serum IgE tests. If you do the test, again, in a random sample of adults, you'll find that 15 to 25% of adults have a positive skin test or blood test for Venom IgE, which is why we don't have a screening test, because the presence of IgE, as you know, is necessary but not sufficient for allergic reactions, and there are many people with asymptomatic sensitization. And this is true for peanut, for venoms, for cat, for pretty much any allergen, and it certainly is true for venoms. There are a lot of people who are sensitized. In fact, people who have been stung in recent months can have up to 40% frequency of positive skin test for serum IgE for venom. Although that can be transient. We came back a few years later and retested people, and we found that 30 to 50% over a period of years had lost that sensitivity. But while they had it, so this is now people who are history negative, skin test positive, if they got stung, about 15% had a systemic reaction. But when you take all those numbers together, it still doesn't make a case for screening the population. But that's we'll come back in the very last slide, actually, to some issues about how we quantify risk and how much risk is acceptable to us, how much is acceptable to our patients. And that's a very core issue in insectology and venom immunotherapy. It's kind of a no-brainer to say that we need to do something when they have a 50% chance of having another systemic reaction. But what about if it's 20% or 10% or 5%? And those are the judgments that we make, and you'll see that as a kind of a recurring theme. And the last point on this slide is that half of fatal reactions to insect stings occur on the first reaction. Not the first sting, which theoretically is impossible, but the first reaction. And they're not preventable deaths. We don't test people who have a negative history. We try very hard not to, because we find a lot of positives and then we don't know what to do with it. So it's not preventable if it happens on the first reaction. We were talking yesterday about whether we have decreased the number of deaths in this country from insect sting anaphylaxis with the use of venom immunotherapy. The answer is we don't think we've made a dent in the deaths at all. Partially for this reason, partially because we think that we're treating the tip of the iceberg, that 90% of people with insect sting allergy don't tell their doctors, and the doctors don't ask. So they're not being referred, and even when they know they've had insect sting anaphylaxis, they're not being referred. So I think all of that comes together to say, well, we have not made a serious dent in the deaths from insect sting anaphylaxis. So when the patient comes to see you, how do you assess the risk of insect sting allergy? Well, the usual history, diagnostic tests. You have to know something about the natural history. This is true for every disease, of course. What happens if you don't treat them? Will they get worse? Will they get better? We'll talk a bit about that. We more and more now measure, and I'll talk about it, the baseline serum tryptase. And we try to evaluate the impact on their quality of life, because that definitely comes into play in some of our decision making. And then some of the softer issues, if you will, about age, underlying medical conditions. The majority of the fatal reactions occur in those over age 45. I used to call that old. I no longer call it old. The history going on here about, and we're going to run through these modalities of evaluation. Dick Lockey, when he did this registry of 3,000 or so patients across the country with insectology back in the early 80s, found that in the children there's a tendency to the milder cutaneous systemic reactions. We actually found closer to 60% in our pediatric population had a history of just cutaneous, meaning hives, swelling, perhaps flushing, although we really don't see that in kids. Moderate would be that they had some throat tightness or some dizziness, but it wasn't bad. And severe would be that it was bad, that they had significant impairment because of hypotension or respiratory distress. And not shown here is extreme or near fatal, which is exactly what it sounds like. Unconsciousness, hypoxia. in this survey, it's kind of all folded into severe. So what you see is that children actually very uncommonly have severe anaphylactic reactions to stings, whereas in adults it's far more common as we get older to have much fewer of the milder reactions and many more of the more severe reactions. The respiratory tract is affected about equally between kids and adults, but the kids have much more frequent mild cutaneous reactions, and the adults start to get into the hypertension, which we almost never see in kids. Again, history. This is a study this was part of our Sting Challenge studies at Hopkins, in which we were stinging untreated patients with a history. So this is history positive, skin test or IgE positive. These are people that should go on Venom immunotherapy. But they refused Venom immunotherapy, and we convinced our IRB that that was a good enough reason to sting them. And we did. Yeah. It's interesting at Hopkins. They've gotten so used to us stinging people, they think nothing of it. And the point on this slide, this is their history: mild history, moderate history, severe history. And you can see a kind of linear correlation here between the frequency of systemic reaction. So that's frequency, not severity. Their skin test and blood tests, we'll come back to this in a second, don't predict severity. They only predict the frequency of reaction. The prior history is actually one of the factors that most accurately predicts the severity of future reactions. But this is just showing the frequency of reaction. But the different bars here was a kind of side observation, which is kind of interesting because we've always noted that the reaction to insect stings is kind of unpredictable. One time they get stung and have a severe reaction, then they get stung and they have no reaction, then another time they have a reaction again. There are a number of possible reasons for that, and this is one of them. 2 different species of yellow jacket. And unless you're an entomologist, I challenge anyone in this room to tell the difference between Vespula maculifrons, which are the ground nesting yellow jackets that you run over with your mower, which are very aggressive, that's the red bars, and the Vespula germanica, which is still very happy to sting you, but they just don't seem to cause as severe reactions or as frequent reactions. So what you can take away from this slide is that if this person got stung with the Vespula germanica, in the blue bar here, let's say, then there's only a 12% chance they're going to have a sting reaction. If that same person gets stung next year by the Vespula maculifrons, then there's going on 25% chance of a systemic reaction. And even more so, the difference in the severe reactors. So species differences, even in obviously related insects, even more so when it's a difference between yellow jacket or wasp or yellow jacket or hornet. And people, including physicians, are notoriously unreliable in identifying the species of the stinging insect. Most people don't really hang around to take a careful look. Yes?
How was this like several years afterwards? What was it?
So it varied. That's a good question. How long ago was their sting reaction? And there was a wide range here. In some cases, it was a year or two. It was not real short. It was not the same year, I don't think, in any of them. And it could have been 5 years or 10 years. They were all, they all qualified for Venom immunotherapy, meaning that anyone who had a systemic reaction and still has IgE is a candidate for Venom immunotherapy. But to go to your question, what we found, and so did Bob Reisman in his studies, is counterintuitive. It's exactly the opposite of what we always said, that the risk goes down with time. We did not find any difference whether they were stung 2 years ago or 10 years ago or more. History positive, skin test positive, they have a chance of reaction, and we didn't see any correlation of that frequency of reaction to the time since they were stung. So this is diagnostic testing now, and looking at skin tests, and I could show you very similar for serum IgE. And what you see, so the skin test the concentration for a positive skin test, whether it's 0.01 micrograms per mil on up to 1 microgram, the last bar here is patients who were skin test negative but serum IgE positive. And again, you see this roughly linear correlation of the frequency of reaction. The stronger the test, the greater the chance of reaction. The skin test negative RAS positive had the lowest chance of reaction, which is interesting in itself, but I'm hesitant to say that it's an across-the-board observation. We I haven't seen anyone else really examine that question. What's the meaning of a positive blood test if you have a negative skin test? Sorry. So again, I'll emphasize that the strength of the skin test or serum IgE does not predict the severity of reaction, or not reliably. Yes, there's a correlation, but there are clearly people who have a strong positive test and they get either no reaction or large local reactions. And there are people who have barely detectable Venom IgE and they go into shock, which incidentally, and you'll see this later on, rapid onset hypotension without hives and barely detectable IgE is mastocytosis until proven otherwise. So there was a lot of concern some years ago, and many of you will know exactly why, about negative skin tests. And what are we missing? Because there was a particular case, and there have been others, of people with negative skin tests who went on to have severe, life-threatening, or fatal reactions. So we went back, and this is still the same sting challenge study that we were doing between 1997 was our first summer stinging, and into about 2005 or 6. Like I said, we recruited by advertising and by phone, and from within our patient population, patients who had a significant history and declined Venom immunotherapy. So we found that 68% of the people we tested were positive skin tests. That's a really low number. And yet when we look back at other large studies, including our controlled trial in the 70s and Van der Linden study of 300 plus people in the Netherlands, exact same number. If you look back at Kevin Hunt's paper on the Venom immunotherapy control trial, they had to exclude 1/3 of their candidates because of negative skin tests. I don't see that at that low a number in my practice. I don't think 1/3 of my patients with convincing history are skin test negative. It might be 20%, which is still a pretty fair number. But many of those have a positive serum IgE test. So in the end, if we did both tests, we had a confirmation of the allergy in 82% of the people we tested. That still left these 18% who were skin test negative, RAS negative. And I'll use RAS because in those days it was a RAS. And those are the ones that were worried, like, what does that mean? And what do you tell patients when they say that they broke out in hives and they were dizzy and they had throat tightness and the tests are negative? Well, one thing from this study you could say is that they have a 6%, 1 out of 18, chance of reacting to a sting challenge. That still is not zero by any means, but at least we can say that the great majority of patients who are skin test negative, RAS negative, don't react to a sting, even though they have a positive history, meaning they have presumably outgrown the allergy. But it does mean we're missing some. And out of 300 individuals screened, that was this 1%. Skin test negative, RAS negative, sting challenge positive. That's what we're missing.
And does that include the tryptase negative, or have you excluded them out yet?
No, it does not. Skin tests sometimes have their problems, as do the blood tests. One thing that is not well known is the variability of Venom skin tests. There is a published report from Arnon Goldberg's group in Israel showing that skin tests to Venoms can go up or down 1 log or 1 concentration in probably half the patients that they tested. And that can lead to missing something. This was part of our large local study where we actually screened the patients and then they came back for a qualifying sting to see if they would get a big enough swelling to qualify for the immunotherapy study. So these 2 tests were separated by somewhere between a month and a year in some cases. And what you see, if you can see the faint lines here, these are the ones who were identical on both occasions, whereas here you have 4 individuals who became more strongly positive, and here you have a bunch who became less positive between those 2 dates, and 3 patients who had been positive at 1 microgram per mil and now were negative. And it can go, we didn't pursue the other direction, but Dr. Goldberg did take patients who had been negative and then retest them, and some of them were positive. And his point is that if the patient's positive to yellow jacket and negative to hornet, then you might justifiably say, well, we're going to treat them with yellow jacket venom. but if you test them a month later, they actually might be positive to hornet. And you might have missed that if you didn't. So we're actually in the next update of the practice parameters, which we've just started to work on. We're going to have to consider this question of whether it's advisable to test either to repeat skin test on a second occasion or to perhaps get a skin test and a serum IgE test to try to make sure that you're not missing one of the venoms that perhaps should be included in venom immunotherapy. I don't know the explanation for this. We had a hypothesis originally that it was unidirectional, that it was becoming less strong for a variety of reasons, but we were wrong. It can go in either direction. And that's what Arnold Goldberg reported also, so I have no explanation for it. I've asked Hal Nelson, and he has no idea. But his theory is that it's because it's intradermal and not puncture. And I've found some other references to variability of intradermal skin testing. And maybe that's the answer. I really don't know. We can't compare it with puncture testing in these patients because there really are no useful puncture tests for venom. I'm going to say relatively little about some of the new and upcoming methodologies, partially because you can't order these tests, and because it would get into a whole nother lecture. Basophil activation tests is a way of doing something just a little shy of a histamine release test. In other words, you take the patient's basophils and you put yellow jacket venom in the test tube, but you put it at a much lower concentration than what you would do to release histamine. And what you get is activation of the basophils as shown by increased expression of activation markers like CD63, but you don't get mediator release. So this is a subthreshold stimulation, and it's measuring, in a sense, the sensitivity of the basophils, which is another thing that it's called, basophil activation or sensitivity testing. And it's kind of the same as what our former division chief, Larry Lichtenstein, in the 60s and 70s would have called twitchy mast cells or basophil hyperreleasability. But there's definitely a difference in the responsiveness of basophils in different individuals. And it's been evolving over a number of years in a very positive direction, but there's still a lot of concerns, at least on this side of the Atlantic. I'm talking for the West Coast, that's a little tricky. Our side of the Atlantic has concerns about these European studies that use different methodologies, they have different ways of analyzing the data, they have different ways of expressing the results. If this is going to happen in this country, I think we're going to have to all talk the same language. We're going to have a test that is done the same everywhere that it's done. You know, our serum IgE tests are standardized. When they can standardize the basophil activation test, it may turn out to be extremely useful, including for non-IgE. They purport to show that this works in drug allergies where we are unable to detect IgE and radio contrast media sensitivity. So it's an interesting methodology because it's directly exposing the basophils to the suspected cause of the mediator release. So we've seen a number of studies showing that it can, in this study, for example, it was more sensitive than intradermal tests in detecting the allergic patients who had negative serum IgE and negative puncture tests, which I don't know about you all, but I don't do puncture tests with venoms. You can, but you're not going to find very much normally. It can predict failure on treatment. It can predict relapse after stopping immunotherapy. So I use these references, and there will be a couple of other slides also coming up where the handouts will help you to track this down and look more into it if you have interest in doing that. The other approach, of course, is recombinant venom allergens, and we're hearing a lot about this in component resolved diagnosis for food allergies, notably peanut. It's being looked at in venoms for a number of reasons. The European approach is mainly looking at what they call dual sensitization. Someone who's positive to yellow jacket and honeybee, and do they really have two separate allergies, or is there a cross-reactivity possibly related to cross-reacting carbohydrate determinants? And using recombinant allergens, which are expressed in vitro without, so they do not express the carbohydrate moieties, and that might be an advantage. The problem is that although there are studies like Ulrich Mueller's showing that if you use recombinant allergens, you can separate out the true double sensitization from the cross-reactive. When it comes to more accurate diagnosis overall, there are a number of studies, and more, I'll have to update these slides for 2012 and 13, because there's almost an explosion of papers, all of them pretty much showing that if you use limited allergens, you get limited answers. That if you're going to use this for a more accurate diagnosis, that it's going to have to contain multiple allergens. APM1, APM2, BESV1, BESV5. There's going to have to be a repertoire of allergens, because if not, you're going to miss somebody. And that's exactly what they found, that to get diagnostic sensitivity anywhere close to Venom skin tests, they had to include pretty much every known allergen in the Venom. Yes?
They looked at the difference between the two yellow jackets, because now you're talking about difference between different bees, but you had the distinct difference in the yellow jacket.
No, not that I know of.
So it's not more.
And although BESV5 is the major allergen in all yellow-jacket venoms, and in hornet venoms for that matter as well, and yet there are patients who are positive to yellow-jacket and negative to hornets, there's just enough variability even in BESV5. The molecules are not totally identical between different species, and that's how you get sometimes species-specific sensitivities. This study from 2009 looked at some 379 total individuals here with insect sting anaphylaxis, and first of all noted that 11.6% of them had an elevated baseline serum tryptase level. So that's one. We're going to look at the top line. We're going to look at the bottom line. The bottom line is the grade 4 reactions, in other words, hypotension. And 31 out of 124, 25% of patients with insect allergy with hypotension had an abnormal baseline serum tryptase. So, like I said earlier, hypotension is the manifestation that correlates most closely with elevated baseline serum tryptase, but there were some, 5 to 10%, even in the milder reactions, that did have abnormal baseline tryptase. And on this line in the middle here, allergy tests for Venom, negative tests, you'll notice none of them were negative in the tryptase normal group, but there were some that were IgE negative in the tryptase positive group. And that goes to what we said earlier about possible reasons for having anaphylaxis without IgE. Tryptase, in this European study, multi-center study, they looked at the correlation of baseline tryptase with the odds ratio for severe systemic reaction to stings, and found a basically linear correlation here between the tryptase and the odds ratio for severe reaction. And although, as you know, 20 micrograms per liter is the cutoff supposedly for investigating for mastocytosis, by the time we get to 20 in this study, they have an almost 5-fold increased chance of severe reaction. Even between 11 and 20, which is that intermediate range that it's abnormal, but it's not over 20, they already have a 2 to 3-fold higher risk of severe anaphylaxis to a sting. The assumption here is that we're describing, again, people with leaky mast cells, hyper-releasable basophils, the kind of thing we were saying earlier about basophil sensitivity, as to why they would be leaking tryptase, if you wish, because the great majority of these people don't have mastocytosis. When we get out to these relatively fewer patients at this end here with tryptases of 20, 30, 50 and more, there's obviously a much better chance that they have mastocytosis. But the bulk of them were all in this range. The mean incidentally, in the adult population is 4.5. And I have seen patients who had a tryptase of 9, that's normal. But when I did it a couple years later, it was 14. And in at least one patient, when I did it a few years later, it was 22. So I've started to actually follow some of them, and especially the ones with hypotensive shock. That's clearly the part that correlates most closely with tryptase. And although I'm going to say not very much about mastocytosis, I'll point out that Hymenoptera stings are the most common cause of anaphylaxis in patients with mastocytosis, and are one of the most common presenting signs of indolent systemic mastocytosis, is anaphylaxis to a sting, especially with hypotension. And of course, there's foods, there's idiopathic and all kinds of interesting combinations in mastocytosis patients that can cause anaphylaxis. But since I've started measuring tryptase in my severe reactors, I have found quite a number of abnormals, and I've diagnosed 2 cases of mastocytosis that had no other manifestations. Their only manifestation was that they had anaphylaxis to a sting, and elevated tryptase, and an abnormal bone marrow when we did.
So patients who have been on VIT forever, because they are a hypotensive person, it would be beneficial to check their tryptase.
Yes, and we'll come back to one of the main reasons when we talk about discontinuing therapy. And actually it's going to show on this slide. Because elevated tryptase correlates with more severe reactions, like you just said. It correlates with more frequent systemic reactions to the Venom immunotherapy itself. It is related to more frequent treatment failures. So patients on Venom immunotherapy with mastocytosis don't have as reliable protection, and more frequent relapse after stopping Venom immunotherapy. In fact, the only cases, and I think there's 3 or 4 now, of fatal insect sting anaphylaxis after Venom immunotherapy were all in patients with mastocytosis. So if you stop those patients, they have a risk of death from the sting. They're on for life if they have mastocytosis, and perhaps even if they have a significantly elevated tryptase without mastocytosis. So here's the patient. How do we know whether they need Venom immunotherapy? Well, the official indication is very simple. Positive history, positive test. But then we get into this, what do you mean positive history? Life-threatening reaction? Yeah, I'll buy that. Moderate systemic reaction? Yep, I'll buy that too. But we get into the low risk. I said earlier, what if the risk is 10% or less of a systemic reaction? Like in large local reactors, like in cutaneous systemic children, at least. And although we make recommendations that Venom immunotherapy is not required in these low-risk individuals, we're not saying they're never going to have a systemic reaction. We're saying that it's not cost-effective to treat 100 people when only 3 are ever going to need an epinephrine injection for a sting reaction. So this is the gray area, if you will, the judgment that we all make when we see patients. So I mentioned that we've done sting challenge studies. This is how we do it. The entomologist from University of Maryland that we've worked with for years created this sawed-off shotgun. And it's very efficient, and we actually proved that we can ship it overnight. So if you want to do sting challenges, we can ship you yellow jackets.
You can come to my yard.
Well, that was before that was invented, and what almost, I wouldn't be standing here today because I can remember as a fellow when I started working in these studies, and our beekeeper, who was our supplier at the time, didn't show up. Me and the study coordinator were out in the courtyard with a Coke and a donut trying to collect yellow jackets. And I said, this is not in my job description. So we landed up going to an entomologist who was very reliable. And actually, when I showed you the data earlier on the 2 species of yellow jacket, that was an incidental finding. In the second year of our sting challenge study, all of a sudden our reaction rate dropped off tremendously. We said, what's going on here? And it was the entomologist that said, well, it was a lot easier to get the Germanica than the maculifrons because they don't sting me as much. So we said, no, we analyzed the data and came up with that figure that I showed you. And then after that, we stung only with the Spielen maculifrons.
Is that true of all of the Hymenoptera, that there are sub-variants?
Well, among yellow jackets, that is true, and although I've mentioned 2 species, there are comparable species in pretty much every geographic area in most areas of the world. In other words, there's the really bad yellow jackets and the not so bad yellow jackets in pretty much every area, even though they have somewhat different species names. But what we call hornets are actually aerial yellow jackets, so it's just another species of yellow jacket, in a sense, the Dolichovispula. The Vespa, the European and Oriental hornets, actually have the same allergens, but I don't know offhand whether there are variations in those species. And amongst honeybees, not that I know of.
How about bumblebees?
Bumblebees are definitely different from yellow jacket. I can remember years ago we said, well, they're kind of cross-reactive, and if you test them and they're positive to honeybee, treat them with honeybee because it's better than nothing, which might be true, but it's not. It may be better than nothing, but it's not very good because in the studies in Europe, bumblebees are used for greenhouse horticulture, basically, and so it's an occupational allergy in greenhouse workers. And there's a European group that has looked at this and has done venom immunotherapy with a bumblebee venom that they create in-house. But those patients, the majority of their patients were not positive on any of the tests for honeybee. So there is a serum IgE test you can order for bumblebee, but there's no skin test and there's no venom immunotherapy.
If you have someone who comes in and they were stung in Australia by, they tell you it's a yellow jacket, and you do your testing and they're actually positive to your testing, you put them on immunotherapy. Are there enough cross-reactive proteins that you would be covering for them for that?
Yes. One day I'll publish that paper. It's been on my computer for about 30 years. Yeah, one thing about being in private practice is that it's harder to write papers. We did that years ago. There were some problems in that study, which is the reason I never submitted it for publication. And it turns out that one of those problems was that our beekeeper was bringing us yellow hornets instead of yellow jackets, which made it hard to publish the data. But yes, we showed that in patients who were positive to yellow jacket and wasp, that we did screen them by RAS inhibition. And if they showed cross-reactivity by RAS inhibition, and we treated them with yellow jacket alone, when we stung them with a wasp, none of them reacted. We could cross-protect them. If they're cross-sensitive, then they can be cross-protected. But we did screen by RAS inhibition. We don't know what would have happened if we would have taken all comers, including the patients who had, according to RAS inhibition, dual sensitization. You can be allergic to wasp allergens that don't cross-react with yellow jacket. So it's kind of like what I said about honeybee. You could be allergic to both, or you could be cross-reactive. And you can order a RAS inhibition test from the Hopkins Allergy Lab, JACI Lab. I've been able to get most insurances to cover it when I talk their language, meaning money. When I write them a letter saying that this $250 test may save them thousands of dollars over the duration of treatment, they usually say, okay. But it's the only lab that does the test. And no, I have no conflict of interest. I have no actual involvement or interest in the Hopkins JACI laboratory. So this is almost everything that's ever been published on what happens when you sting people who are not on venom immunotherapy. History positive, skin test positive, and they get stung, and you see a wide range from 30% up to 65% chance of reaction, systemic reaction to a sting. That's a pretty wide range. And there are a lot of possible explanations, because some of these studies use sting challenge, some use field sting. Some included children, some did not. Some included large local reactors, some did not. It was interesting that a couple of the largest studies were the ones with the lowest reaction rates. And that actually, those were 1994, that's actually what got us back into doing our sting challenge study that I said we started up in 96, 97. Because we didn't believe this and we thought we could prove that they were wrong. We didn't, we proved they were right. But it's all about what kind of patients you sting. And to illustrate that, I'll focus on Bob Reisman's study here, another large study, 220 individuals, very kind of middle of the road. And incidentally, the bottom line literally is where we get this idea that there's a roughly 50% chance of systemic reaction to a sting in history-positive skin test negative individuals. Seattle, who's calling me in Seattle? This is terrible, but I'm actually going to try to find out if this is like my brother. Hello? Yes. Okay, it's likely that I'm going to be delayed and probably not out there till around 8:30. I'll see you then. Bye. All right, got to make sure he doesn't leave without me. Sorry. So I said I'm going to focus on Bob Reisman's study because he broke it down in a number of ways. And again, his study included a variety of patients, but when he broke it down, you can see the difference in reaction rate between the children and the adults. I mentioned earlier that he found, like we did, that there was no decline in the reaction rate over a 10-year period. So the fact that they got stung 10 years ago versus 1 year ago, amazingly, did not make any difference in his analysis. And he also found, like I've been saying, that there's a variable reaction. Sometimes they react, sometimes they don't. And I blame that primarily on the insects, meaning that yellow jackets can deliver anywhere between 2 and 20 micrograms of venom protein per sting. That's a 10-fold difference in allergen exposure, and you can imagine that that alone could account for differences, and the species differences that I pointed out earlier. So, if you do a single sting challenge, is that enough? And Franken in that 1994 paper was the first to report that if you took the patients who didn't react to a sting challenge and stung them again, that 21% reacted on the second one. Again, this goes to the variability of reaction to a sting, and we confirmed that this was prospective in our sting challenge study, so we basically found the same thing. Sting challenge has its problems. It's the gold standard in research, but we have to take into account that a single sting is not totally reliable as a probe of clinical reactivity. We published this paper on long-term follow-up of children, and I'm going to focus for a moment on the cutaneous systemic reactors because my colleagues Marty Valentine and Ken Schuberth reported years ago, and it's that single study that is the basis for our clinical practice now of not recommending venom immunotherapy to children with cutaneous reactions because they have an approximately 10% chance of another systemic reaction, but it was virtually always going to be the same or milder, meaning hives, than their original reaction. The chance of getting worse was very small. And this is now a long-term 15 to 20-year follow-up of these kids, and we found that it was not getting less. These patients were now in their 20s and early 30s, and they still had this roughly similar chance of reaction. And in correcting for probable selection biases, we estimated about a 3% chance that they would become worse on a subsequent sting. The ones who had more severe systemic reactions and didn't go on venom immunotherapy, there were parents who said, no, I'm not putting my kid on shots. The long-term follow-up, it's only 7 out of 22, it's a small number, but clearly there were those who did, again, 10 to 20 years later, have another reaction, some of which were severe. So the point there is if someone comes to you in their 30s for hay fever, and you ask all the right questions, and they say, oh yeah, I forgot about that. I nearly died from an insect sting when I was 7 years old. But I've outgrown it, right, doctor? No. You should test them, and if they're positive, they actually should receive venom immunotherapy that's in our opinion. The large local reactors, consistent with all other reports, although again, this is like 10 to 20 years later, 7% of them had a systemic reaction to a sting, which is right in the ballpark. Many of them were mild, a couple of them were more severe. The severity is unpredictable in the large local reactors. So what about adults with mild systemic reactions? In this country, in contrast to the rest of the world, it's recommended that they should have venom immunotherapy. In our sting challenge study, of 81 patients, adults with mild systemic reactions, of course only 15% had a systemic reaction. There were 2 of those 81 who got worse. They didn't become severe. They did develop throat tightness or slight dizziness. None of the moderate reactors became severe. So we feel strongly that the chance of progression is actually quite small in these patients. And we're thinking, as a work group for the practice parameter, we've had this discussion about whether we're ready to recommend for adults the same or similar to what we recommend in children, that they may not require venom immunotherapy. Because Franken study 1994, I've shown you that one a couple of times, actually showed the exact same thing. In 324 patients that he stung, he had near zero progression from mild to moderate or more severe reactions. There are 2 retrospective studies that show more frequent progression, but the retrospective studies clearly have more selection bias, reporting bias. It's easier to believe the 2 prospective studies than the 2 retrospective studies. But it's still an open question, and the official recommendation is still to treat those adults. Don't drink from straws or canned beverages outdoors without making sure you look inside, or just don't do it at all. This letter to the editor of New England Journal was of a 51-year-old man who presented to the emergency room with acute onset of chest pain. They ruled out MI, they got in the endoscopist, they did not find esophagitis, so they looked down in the stomach and found this mislabeled bezoar, because it's actually a yellow jacket zoar. So yeah, his acute onset of chest pain occurred while he was drinking outdoors from actually I don't know if they said whether it was a beer or a soda or whatever, but it was something he did not look inside of. And every year I hear about people getting stung in the tongue or throat. And I mention it at this point because it's the only true danger of large local reactions. Because if you get stung in the tongue or throat, you could wake up in the morning with airway obstruction, or worse. So we did a trial of venom immunotherapy because the patients were asking us for it. We don't recommend venom immunotherapy for large local reactors, but there were patients who were telling us that they're landscapers or golfers who were in the rough a little too much, and they were getting stung almost every summer, sometimes more than once a summer, and having severe large local reactions that required steroids. And we said, all right, we'll try this. We actually didn't think it was going to work. It did. In the first summer, we had a 40 to 50% reduction in the size and duration of the large local reactions. And after 2+ years, we had a 60% to 70% reduction and a near 100% patient satisfaction rate in the reduction of large local reactions to stings. So for patients with frequent and severe large local reactions, it does work. It's a steroid-sparing therapy, if you will. And I've had very, very few patients over the years that I felt needed this treatment. Because if you get a large local reaction once in a while, then it's not so reasonable to recommend venom immunotherapy. I don't have to belabor the controlled trial of venom immunotherapy, Hunt et al. New England Journal, 1978. I'll just point out that in the placebo-treated patients, which are these two groups here, it's not worth going into the history of whole body extract, but it's enough to say that it's basically placebo. Why weren't they all stung? And the answer is because 2 of them landed up with protracted anaphylaxis with an overnight stay in the intensive care unit, and the study was stopped. And those patients were crossed over to venom immunotherapy, and in the end, out of 55 patients who were treated, only 1 had a systemic reaction to a challenge sting. That's where we get our 98% efficacy of venom immunotherapy. Although maybe now's a good time to point out, that was predominantly mixed vespid venom. Venom immunotherapy gives complete protection in 98% with mixed vespid, 90 to 95% with any single vespid, and 75 to 85% with honeybee. 100 micrograms is not fully and reliably protective for honeybee. There are some experts, including me, who would, if I have a beekeeper with honeybee allergy, I'm going to recommend 200 micrograms actually. This is one of those slides that I'm not going to spend time on, but you might want to take a look at it. It's not totally up to date, but mechanisms of venom immunotherapy, everything you know and have learned about the mechanism of immunotherapy has come from venom as a model. Going back to the first and earlier than 05 studies looking at Tregs and IL-10 were the 2 things that came out of these studies by Marek-Jutel and Chesmiakis, and evolving into looking at different kinds of T cells and ultimately demonstrating a role for dendritic cells in the regulation of immune responses, of course, and in the response to venom immunotherapy. So mechanistically, this is the model for venom immunotherapy. Pre-treatment, patients who go on venom immunotherapy, there are these and other studies that recommend the use of antihistamines before each dose, at least during the build-up stage. Ulrich-Müller showed not only that it reduced local and some systemic reactions, but that it reduced the failure rate, the reactions to stings. In other words, it may actually improve the response to treatment. And he did a follow-up paper that looked at the possible mechanisms, meaning that there are histamine receptors on T cells, among others. So it could certainly be immunoregulatory to give antihistamines during venom immunotherapy. This study shows, and it's complicated, but let's look at the right-hand side, leukotriene antagonist, and what you're looking at is the time course of the local reaction in diameter here over a period of visits, so these are injections. But what you see is, and you can just get the gestalt here, that the patients on leukotriene antagonists had markedly less local reaction than untreated or antihistamine treated patients. So when I have patients who are struggling with large local reactions during Venom immunotherapy, I'm already giving them antihistamines before each shot. I will then add a leukotriene antagonist in the hope that I'm going to limit the large local reactions. What's the starting dose of Venom immunotherapy? Well, there are two products on the market, and they actually have two different recommended treatment schedules. So depending whether you use one product or the other, you're either using a schedule that builds up over 8 weeks to 100 micrograms or over 16 weeks to 100 micrograms. They all start with relatively low doses. I never thought of publishing it, but these guys did. They did exactly what we've been doing at Hopkins for the past 35 years, which is using a starting dose of 1 microgram on the first day. That's 0.1 cc's of a 10 microgram per ml solution, which, if you're like most allergists, that's week 3, 4, or more in your treatment schedule. And like these authors, we had a 0 reaction rate to that starting dose. In fact, I now start with 6 micrograms, 1 plus 5 at 30 minutes intervals on the first day. In our studies at Hopkins, we did 1 plus 5 plus 10, 16 micrograms on the first day, and had a fairly low reaction rate. Never at 1 microgram. So if you like that idea, then this should support the idea that you can start at 1 microgram. And you can build up in 7 to 8 weeks very safely, because even the 2 to 3 day rush immunotherapy has no worse systemic reaction rate than the standard schedules that we use. Unlike inhalants, can children get a lower dose than adults? We've been asking this question for 30 years. These two authors finally answered it. And in their studies, the answer was yes. 50 micrograms was just as protective, not only during immunotherapy, but after immunotherapy. And although this was just a honeybee study, so I wasn't totally convinced, but this study included honeybee and yellow jacket and looked at, this is not aligning quite right, but so we're losing one line here, but both of these studies showed good efficacy. You're going to see some reaction rates here that look kind of high, but again, this is honeybee, especially. Which, as I was saying earlier, has less reliable efficacy than Vespids. So problems during Venom immunotherapy, I'm going to speak to a couple of these specifically. I try to ignore the large local reactions. I try to encourage patients to put up with it, because unlike inhalants, where we use so-called maximum tolerated dose, with Venoms, we have a target dose, and we need to reach that dose if we're going to guarantee protection of these patients. And the sooner we get there, hopefully the less they're going to have large local reactions. Pregnancy, I'm going to say, is not an issue, same as any other immunotherapy. And like other immunotherapy, we try not to start Venom immunotherapy in pregnancy, but I have to admit I've done it. And I would do it again if I thought there was a good enough reason. What do you do with the patient who's had systemic reactions to Venom immunotherapy? Well, you start off by doing what you always do. Reduce the dose and build it back up again, and that usually will solve the problem. But then we get into, what if they have repeated systemic reactions? Well, we can pre-medicate them with a variety of things. We can get rid of any but one of the Venoms and try to just focus on that one. In some of them, we've used cluster schedules to build them up over just a few weeks with pre-medication. Rush, omalizumab, I'll show you a couple of those. And in the end, when I do get them built up, I will probably go up to 200 micrograms instead of 100 micrograms. So this is the one study that showed that patients' treatment failures, they had a reaction on Venom immunotherapy, and you'll notice that almost all of them were less severe than pre-treatment, but they were still reactions. But when the dose was doubled to 200 micrograms, all but one of them no longer had a reaction to a sting. So increasing the dose does give better protection, and in this case it was treatment failure, but in some cases of repeated systemic reactions to the shots at maintenance, I would consider doing the same thing. There have been a number of different studies of rush regimens, ranging from the 2 to 3 day regimen like this one, which originated with the Bernsteins in Cincinnati, and up to the 210 minute ultra rush venom immunotherapy, which clearly is more risky. So this is one of those options in patients with repeated systemic reactions to shots. It's interesting that the experience of everyone that I've known who's ever done this has been amazingly good. These are patients who are having systemic reactions to shots, and you bring them in and do a 2 to 3 day rush, and they breeze right through it. And they do really well after that. And I'm sure there's exceptions, but the experience has been remarkably good with this modality to work through problems of systemic reactions. There have been, this is 8 cases listed here. There are a couple more where the answer was to administer omalizumab, and there was one failure. The patient still kept having systemic reactions. All the others did achieve maintenance and did well, and they almost all could stop the Xolair later and do well after 6 to 12 months, but this one couldn't. They stopped Xolair and they had systemic reactions again and had to go back on Xolair again. But it's another option if you have that kind of patient where there's no other way you can work away from these systemic reactions. So I want to take a moment to talk about medications, meaning beta blockers and ACE inhibitors. So this is that study, the European multi-center study that I showed you that showed that tryptase was a risk factor for more severe reaction. But the top 2 lines here are beta blockers and ACE inhibitors. And actually the ACE inhibitors were more statistically significant risk factors than the beta blockers. The only problem I have with that is this study that was published just a couple of years later, Stovacant et al., that looked similarly at factors correlating with severe reactions to insect stings. And first of all, what were the risk factors? Elevated tryptase, absence of cutaneous symptoms. I said earlier, if they don't break out in hives, then that is a risk factor for more severe reaction and a possible marker of mastocytosis. The more rapid it comes on, the more severe it's going to be. Latency, age was a factor. So where are the beta blockers and ACE inhibitors? Down here. Not even close to significant. So how is it that we have 2 radically different observations from 2 different groups on the same question? And I don't know. But it points to the fact that this is not a settled issue. I mean, is it patient selection? Is it in certain criteria? I mean, I've looked at the papers. I still don't know why these came out with such different results. And the practice parameters do say that you should be cautious and try to eliminate these medications. But remember that it's not an absolute, it's a relative contraindication in venom immunotherapy. We do treat patients on beta blockers and ACE inhibitors. And so far, I'm agreeing with these guys. I have not seen it as a risk factor.
You have them hold the dose on that data and getting a shot?
I'm sorry?
You have them
Hold the dose. If the cardiologist or prescribing physician is okay with that, so if they have severe tachyarrhythmias, maybe not. So I try, but with the extended release products now, you'd have to consider holding it for 48 hours, not just 24 hours. I'm going to skim very quickly through some of the last slides here. We do recommend 4 weeks for a year or year and a half, and then 6 weeks interval, and then 8 weeks. And later in treatment, I'm very comfortable with 12 weeks. There are recommendations to monitor skin testers' specific IgE, and of course, at every visit, we're asking them, are you on any new medications? Because people get put on beta blockers and ACE inhibitors. So these are some of the studies on the 3-month interval. And I wasn't totally convinced when Goldberg published his 3 consecutive papers of the same study, but with this new study now I'm more convinced. And I'm getting more and more comfortable with not only recommending 12 weeks late in treatment, like in year 4 or 5, but possibly even early on, because these patients went on 3-month interval. They were on 4 to 6 weeks for 3 years, and then they went on 12 weeks. So into the 4th year, I'm considering this more and more in my patients to allow them, if I've already worked them up to 8 weeks, then I will consider letting them go 12 weeks. But I never tell them it's 12 weeks. I always tell them it's 10 to 12 weeks. Because what we learned from extended interval studies is the longer you let them go, the more they forget. And we try to find ways to avoid that. So when do you stop venom immunotherapy? Is it based on time? Is it based on test results? Should you be doing skin tests or serum tests or tryptase like you asked before, or history? What are the important variables here? And the answer is History, absolutely. Tryptase, absolutely. Diagnostic tests, useless. I do them, but they do not tell you anything about whether you should or shouldn't stop immunotherapy. We found that IgE and skin tests do go down steadily with time during 6 years of immunotherapy and in the 5 years after stopping immunotherapy, despite the fact that we were stinging these patients every 1 to 2 years. So the first observation was that they weren't going to get resensitized. Their IgE and skin tests didn't go up after the sting challenges. And when we stung them, we had a reaction rate of about 10% per sting. And whether they were off treatment for 3 years or off treatment for 10 years, they still had a 10% reaction to sting. And this just blew us away. Because a lot of these patients were now stinged after 10 years off treatment were skin test negative. And some of them had reactions to stings. They were all IgE positive. I have to tell you, our lab can detect very low levels of Venom IgE. None of them were IgE negative, but many of them were skin test negative. But the reactions were almost all much less severe than the pre-treatment reactions. There were 2 patients who required epinephrine, and it turns out that both of those patients had risk factors that we now know we would not stop their treatment. So if we had used our current criteria, we would have had an even better success rate in this study. Ulrich Mueller, after initially saying that 3 years was enough, later showed that there's a very significant difference in the relapse rate between less than 50 months and more than 50 months of Venom immunotherapy. So he does recommend that 5 years is better than 3. There was a study out of Mayo Clinic, Keating and Younginger, who found that 5 years is better than 3. So that's definitely my recommendation. This is that study that I mentioned earlier that we did a 10 to 20 year follow-up in children. And when you look at so over here, the moderate to severe reactors who had Venom immunotherapy, and now this is 5 to 10 years after stopping Venom immunotherapy, had a 5% reaction rate, which is even better than the 15% cumulative rate in adults. So this is arguably the most impressive demonstration of immune tolerance with immunotherapy of any type in children with insect sting allergy. If they have a reaction during Venom immunotherapy to a sting or a shot, they have a much higher risk of relapse. So this is leading, and the more severe the history, the more the chance of relapse and the more the chance of a severe reaction. So this is the list I wanted to get to of why would you maybe not stop immunotherapy after 5 years? And the answer is extreme or near fatal or very severe reactions. I mentioned systemic reactions during treatment, elevated tryptase or mast cell disorders. Honeybee allergy has a significantly higher relapse rate, so beekeepers should probably stay on longer. And sometimes quality of life. Because I have patients who I really think they could stop treatment, but they have frequent exposure, they're really afraid, it's going to affect their quality of life. Sometimes that's a good enough reason to continue. And this is the last slide I said I was going to come back to as far as risk evaluation. And it's the question that I often get asked, what about epinephrine injectors? When do you prescribe epinephrine injectors? Well, some of that is obvious, but it's the low-risk situations. The large local reactors, the kids, if you're on Venom immunotherapy, when you stop Venom immunotherapy, I have patients who say, well, my brother or my daughter or someone in the family, I'm afraid for them, I want them tested. And I say, no. Then they say, well, I want an EpiPen. And I say, well, let's talk about it. But these are the low-risk situations. And it's a judgment call, bottom line. The rest of the world laughs at us, frankly. They think we're absolutely crazy for the extent of epinephrine prescriptions that we use, sometimes for very low-risk individuals. But they practice in a different system than we do, clearly. And when there is any perceived risk of anaphylaxis, you have to consider prescribing an epinephrine injector. And that's the only way I can answer this question, is that you've got to make that judgment. I try to persuade some of these patients that they really don't need one, but I'm perfectly willing to prescribe it if that's going to make them happy. EpiPens do not improve quality of life in randomized control studies, but in patients who choose EpiPen, patients who didn't agree to randomization in those studies, they actually did have improved quality of life just by having an epinephrine injection. So it could be a reason. So I'll stop there, and although I'm happy to take questions, do we want to do the case presentation first?
Yeah, well, we know your driver is an hour early.
Yeah.
So, Aaron, why don't we just move to the presentation?
Take home message. Yeah. Test any history.
Everybody can stay or so. Let's not get voice here so she can present.
Yeah, but then one of us needs to do one day.
Only do it for as far as what the hours and the night, you know,
Fighting over.
Yeah.
you know what I'm saying?
Yeah.
Senior faculty. Right now, your question is, he does, but now the question is, what do you do with these large lumps? Should desensitize them, it looks like.
Have a light weight.
All about a 13-year-old with a heavy reaction. So basically, a 13-year-old boy that was sent on a Friday. Within several hours, he developed a large local reaction to the site due to swelling in his left hand up to his elbow. His mom initially treated with Benadryl, and they didn't think too much else of it. Then the next day, the swelling increased, and the mom was concerned, so she brought it to the emergency department. At that point, they were sure it was truly large local reaction or maybe more of a cellulitis, prednisone and antibiotics. He went back home, and then later that evening, the boy told his mom that he had a sore throat. It still had been swelling, and then stated that he felt like it was harder for him to breathe. So mom put him back in the car. After some difficulty, at some point on the car ride, epinephrine was administered, much to the boy's dismay. And then he ultimately ended up at Children's Hospital and was admitted. No other prior history except local reactions. There was one person in the family who also had large local reactions to these things. And physical exam, we saw him relatively benign. At the time we saw him, his hand had basically returned to normal. So our plan was to do 5-day course of prednisone, gave him a heavy pen. He did well and was discharged on that Monday. And we referred to local allergist for follow-up. So basically, our questions were that in regards to patients less than 17 years of age with severe skin, and also, kind of more of the question of severe delayed angioedema, when should we test for specific IgE? And in this patient, should we start immunotherapy if he's positive?
What do you think?
I think based on
I don't necessarily know the answer any better than you do.
on
I'll
your
be glad to speak to it, but I'm curious what you're thinking.
Moderate range, so I think you can probably go either way.
My problem is that I have a hard time explaining the delayed, apparently systemic reaction. Although it does happen. And I'm aware of cases that are very, very convincing. In fact, one of them was presented as an abstract by the group in Hershey, Pennsylvania, at the Academy meeting some years ago, because this was a guy who, it wasn't as delayed, but who 4 hours after a sting would go into full anaphylaxis, and then he would have the same reaction to skin testing and Venom immunotherapy 4 hours after the skin test or immunotherapy injection. And they actually admitted him and did a rush immunotherapy, and he breezed right through it and did fine. And I'm aware of cases of hours or even a day or two after a sting having anaphylaxis. I just don't know how to explain it. What's the mechanism of anaphylaxis many hours or a day or two after a sting? So, to go to the question, should we test and consider immunotherapy, I'm skeptical. But I feel like we almost have no choice, meaning that this is a systemic reaction with airway symptoms. So my question is, how fast did he improve after the injection of epinephrine? This was on the way to the hospital?
And so he would improve, but then he'd have these recurrent episodes where he'd say his throat was feeling sore again, and per the primary surgeon.
So they did laryngoscopy, of course. I mean, I don't know how to explain the symptoms, and then I get my usual skepticism about what was really going on here, and what's this child feeling? Should we try to find out for sure by scoping him? Because it's not making sense to me. But epinephrine wasn't given a second time when the symptoms came back. It was?
So he, I think, got a total of 2 or 3
So
epinephrine.
if he improves significantly within 10 to 15 minutes after epinephrine, and then relapses an hour or more later, then I'm convinced it's anaphylaxis. If he had little or no improvement, then I'm really not convinced that it's angioedema. But I guess I'm going to have to feel no choice. You know, look at it this way. This is what we dealt with in our Sting Challenge studies, because we would sting people. I really didn't go into this detail. And we're doing this in an ICU-like setting, monitoring the whole works, and the patient, 5 to 10 minutes after the sting, says, "It's happening again, doctor. I feel dizzy, I can't breathe, my throat's closing, I'm dying, please help me." And we can't find anything wrong with them. All their vital signs are normal, their pulse ox is normal, we did not treat them, and they all get better after 5 or 10 or 15 minutes. So what is that? In our papers, we called it subjective systemic reaction. We started out calling it questionable, but we were told that was judgmental, so we changed it to subjective. But when a patient tells you that in the field that they got stung and they felt lightheaded and couldn't breathe, you're going to take that at face value. This is an anaphylactic reaction, but when it happens in front of you and you can't find anything wrong, you start to wonder what's going on. So this happened in the field. I feel like we have no choice but to take it at face value, even though the time course is really puzzling. But I always laugh when I see them giving antibiotics for these large local reactions. And you know what it is? There's a lymphangitic streak going from the arm up into the axilla or the leg into the inguinal nodes, and it looks for all the world like cellulitis. But I always like to pin down those doctors and say, really? How long does it take to develop cellulitis after a bee sting? 24 to 48 hours? No way. It's got to be 4 or 5 days minimum. I don't know if there's any way you can develop full-blown cellulitis in under 48 hours from the sting. Getting infections from stings is pretty uncommon anyway, but it does happen, but it's usually more delayed. So if they would actually just stop to think about the mechanism, they wouldn't give the antibiotics, they would just give the steroids, which is what the correct treatment would be. And when we call it severe delayed angioedema, that's correct, but it is systemic. It wasn't like the local. Some people will call that angioedema because it was huge swelling, but we're not going to call a local reaction angioedema. We're going to assume that this patient actually had angioedema in the throat.
But it's not objective. This is all
But it's not. That's right.
That's the problem.
I would have loved them to scope him right there and then, get ENT or anesthesia to come down and scope him. Of course, ENT and anesthesia scream bloody murder when we try to do that. If you've had any experience with vocal cord dysfunction patients, you know how hard it is to get that done acutely.
So have you, what's the time course now? Has he been tested?
Yeah, what do we know? What's happening since?
Nothing yet. He's going to
Not
see
yet?
Paul. He's going to see Paul later. So he hasn't done the workup yet. You know, we saw him after 2 days of steroids, and he was totally fine at that point. But when he came to Children's, they did document in their notes facial swelling, neck swelling externally. So I mean, we have to go by that. But, you know, when we saw him, of course, there was no involvement there. So yeah, and he had a normal tryptase.
And his vitals.
He had it
How
all.
long should you wait? What about the old wisdom? How long should you wait before you test?
That was one of the slides I took out of the top. I still remember it. Depends on how you choose to run your clinic. Meaning that most allergists that I know automatically wait at least 4 to 6 weeks. They schedule testing only 4 to 6 weeks or more after a sting reaction. And I agree that that's the way to get the most reliable results. If you test them after a week, half of them are going to be negative. But only half. It's not true that everybody's going to be negative during that refractory period. And if you do, and there's a reference, there's a single paper published, again, it's Arnold Goldberg's group in Israel, that if you did both the skin test and the serum IgE test, that 80% were positive in the first week. The other 20% didn't become positive until they were retested at 4 to 6 weeks. So what I do is, if a patient comes to see me early in the summer, I have a window of opportunity to get this patient fully immunized before the peak season in September, October. So if I'm seeing them in June or early July, and they just had a sting reaction last week, I'm going to do the test right now. Because if I can find the allergy, I can get them up to maintenance dose before Labor Day. But any of the rest of the year, if they get stung in September, I'm going to say, you know what, let's just wait a month and we'll test you, and because there's not a rush at that point to get them started on Venom immunotherapy. But both the skin test and serum IgE test, so we've talked about refractory skin mast cells, but it turns out that's not the only thing that can be negative. The serum IgE test can be negative at 1 week and be positive at 4 to 6 weeks too. Whether that's because IgE has been exhausted, if you will, used up, makes sense, but I'm not sure if that's true.
You said that one test would be negative. Well, you say find the allergy. If you find one, but other, the actual cause is negative, you worry about that, or practically not?
I'm not sure if I'm totally understanding your question. If I find a positive to one venom, and it's that stage in the season where I feel I can get them protected before Labor Day, then I'm going to go ahead. But I'd have to think about whether to retest them later, because maybe I missed the wasp or the hornet or something. Yeah.
One thing, what happens to these insects in the winter? Where do they go?
The workers die. The queen survives. And in the spring, that queen will establish a new nest and start the cycle all over again. But they never use the same nest. They will nest right nearby if they happen to like the location, but they do not reuse the same nest next year.
This is true of all hymenoptera?
Of the vespids, al-JACI, hornets, and wasps. Honeybees have their hive, and they like their hive.
Any other questions you had about? So he hasn't been worked up yet.
I think he's going in this week.
Was his tryptase really high or anything like that?
It was normal, and kids will be even lower than adults on average. So I'm happy to see that. And this was during the reaction, you mean, or baseline?
This is 3 days later.
3 days later. Okay. Would have been of interest to do it during the reaction. But if it had been elevated, that would have been very significant. If it had been normal, it wouldn't have answered our question. But I'm mentioning it just because, what if the tryptase had been 8 during the reaction? You would have said, that's normal. But if you then got a baseline of 2, then you have to go back and say, no, that was not normal. And there are 2 papers published on that subject, one of which recommends, based on their data, that if it goes up 35%, if it's 135% of baseline, then that's a significant increase. I'm wondering what you're going to do in this patient when the skin test and IgE are negative.
That's for Paul to decide.
There was another case last year, I don't know if this was resolved, a patient who had, I think, either mastocytosis or mast cell activation, elevated tryptase, who had an anaphylactic reaction to a sting, but negative testing. Serologic.
Well, this is the case that actually had led to your being here now. When I called you and I said, what do we do with this patient? And you had to send specimens back to the Hopkins lab for more sensitive assays. Told me to push the diagnostic skin testing to a higher. It was all negative.
Really?
Actually,
90% of insect sting allergic patients with mastocytosis do have IgE, sometimes very little. But there are those few who appear to be totally IgE negative, and whether that's just the mastocytosis talking is what we're assuming. So can you do Venom immunotherapy in that patient is the question. And I don't know, actually. I will say that, again, in van der Linden's 1994 paper, if you dig down deep into the data, he had 2 or 3 patients who were skin test negative, IgE negative, but challenge positive. And based on the challenge sting, meaning that he knows he challenged them with the yellow jacket, so he treated them with yellow jacket, and then he challenged them again and they didn't have a reaction. So he was able to show anecdotally that there are patients that seem to respond to venom immunotherapy in the absence of IgE. So it's an interesting question. I'd have to think about that really hard because there might also be an increased chance of systemic reactions to venom immunotherapy in this patient. But that's a hard choice.
When I called you, I think we could find no IgE in this man. He also has not really followed up, didn't come back. You said we don't have the ability to do a sting challenge here, so basically you just said you can't really give him immunotherapy. You don't know what to treat him with.
You would either have to treat with all the venoms, or you'd have to go out on a limb based on his history as to what the most likely culprit was. And frankly, mixed vespid venom, if you wanted to do it, outside of children who run around barefoot and people who garden without gloves, it's not how you be allergic. That's near impossible. And the vespids, especially yellow jacket, accounts for the vast majority of things in most areas that are not involved with high exposure to honey. But whether that's worth actually doing and whether it's going to make any difference, we don't know. It would be an arbitrary choice. I have to admit I'd be tempted, but I keep thinking about how the patient's going to feel about me when they have an anaphylactic reaction to a shot.
We lost follow-up. He actually seemed not very concerned that he had systemic mastocytosis. He just sort of blew it off.
I know, I'm absolutely amazed, because you see the other end of the spectrum of people who were in a total panic over what we consider a pretty mild reaction, and then you have people who nearly died, and they say, yeah, I'm fine, I'm not worried about it, I don't need shots. Yeah.
Is there any family history of, sometimes I get patients who tell me that their grandma, and obviously you don't know completely all the history, but there's an uncle, there's a extended family that all have reactions. Now, I don't sit down and test that, but if that person might be the person I might have my arm twisted to give an EpiPen to.
I agree. 95% or more of people with insect sting allergy have no family history of insect sting allergy. So it appears to be like penicillin allergy, mainly sporadic, but there are some families. Hopkins got into this because there was a beekeeper family in central Pennsylvania that was treated, all of them, mother, father, and 3 children, with the old whole body extract, which was worthless, and one of the kids died from a sting. Did they give up beekeeping? No, they came to Hopkins, where they were so one of the remaining children was the first child to be treated with venom immunotherapy at Hopkins, and then they did a sting challenge, and you can imagine the fear of the parents on this sting challenge, and there was no reaction. That case was published in the New England Journal in 1973 or 4, and that was the beginning of venom immunotherapy, at least in an organized way.
Interesting for those of you who are young, I can remember the advocates of whole body extract, old-time allergists who were wedded to that practice and didn't want to believe this new data. And there were fights at our national meetings. I'm sure I don't know how young you were at that time, but people who would give up this old practice. Absolutely. The product's not made anymore, right?
It is made. It's still technically indicated for beekeepers with occupational asthma to hive dust. These are body proteins, not venom proteins, that they're allergic to. And it's not like there's any data to prove that it works. And I don't know, in this latest round of taking things off the market in this year, I have to look whether they did or didn't leave whole body extract on the market. I would think they would take it off the market, actually. There are no supportive data for efficacy or safety. As of at least a year ago, it was still on the market for that indication. But it certainly did die hard, and it was endorsed by the Academy of Allergy. I think it was JAMA 1965. The Insect Committee of the Academy of Allergy published their recommendations that whole body extract is highly effective for insect sting allergy. It turns out to be useless. And the explanation is all about natural history. We now know that only half the people are going to react anyway on a given sting, and if you include a lot of low-risk people, you're going to get a very low reaction rate. When we analyzed the actual data from those whole body extract studies and put in what we now know about natural history, we came up with a placebo effect of over 80%. So of course it worked.
Well, thank you for a great morning.
Thank you.
To the airport. So your driver called you mid-lecture today. You're here an hour early.
Well, I have to, but I'm always happy to see them come early. It's better than the alternative. More billable hours. Very well.